Hi, everyone. Welcome to our CCRN webinar today, talking about mechanical ventilation. Happy to have everyone here. Looks like we've got some people on Zoom, which is great. This is a CE webinar. So that means if you're joining us via Zoom, then you can be eligible to get a contact hour certificate for being present today for 80% of this webinar. Should be about an hour long, so just 80% of that time. Hopefully you'll stick around for the whole thing. If you are here on YouTube or Facebook, I'm still streaming there. So I did just put the link in the chat to join via the Zoom link. It's still free. So definitely click that link if you're interested in getting a CE hour for this. If you just want the information, then that's totally fine too. Stick around on YouTube or Facebook. Okay, let me just check and make sure everything's working okay. I think so. I don't see any questions yet. I'm going to start where I always do really quickly. I just want to know who's here. Where are you from? If you're joining via Zoom, I've got the chat open here. Where are you from? Or where are you in your nursing journey? Are you a new nurse? Or have you been an ICU nurse for a while, still in nursing school, preparing for your CCRN? I know last time I did a webinar last week, we had quite a few people that were testing for their CCRN in the next couple weeks. So looks like we've got someone from Canada, Paula from Canada, taking their NCLEX soon. Joyce new to ICU. Shakira works in ICU. We've got Victor from Ghana. Amazing. Awesome. Okay, some new faces today. Minneapolis, 5-year nurse, but new to ICU. Oh my goodness, Luke, happy to have you here. That's such a fun transition. Um, from Oregon, new to cardiac ICU, CICU, Elizabeth, Atlanta, Shakira. I've got a lot of CVICU here. Um, Florida, a good amount of Florida. Awesome. Okay, well, so happy to have everyone here. If it's your first time joining us, my name's Rebecca. I'm the CCRN instructor here at Archer Review. And we've been doing these webinars for many months now. A couple months ago, we launched a CCRN prep product. So CCRN is our critical care registered nurse exam. It's a certification exam that you can take once you've been an ICU nurse for a few years. And we love certified nurses. Certified nurses, becoming certified as a nurse is such a good idea for so many different reasons. It really increases your confidence at the bedside, which I know for me, that was a really big reason that I did it. And also your facilities, the ICUs that you're working in will like her. Let's get us back up and running. I think my Wi-Fi just freaked out a little bit. So that's probably what happened there. Okay, can we see me now? Thank you, Ram, for telling me. Yay. Okay, perfect. Hopefully that's the only time that happens. Cross our fingers, right? Okay, so that's a little bit about the CCRNs. If you're joining here and you're still in nursing school, it looks like most people here are in ICU nurses. If you're still in nursing school, welcome. Happy to have you. We will be talking about concepts that may or may not be on your NCLEX, so just keep that in mind. But absolutely so excited. Let's go ahead and get started with some disclosures since we are offering this for a contact hour and giving you a certificate. We've got some disclosures from the ANCC that we'll talk about. So Archer Review is accredited by the American Nurses Credentialing Center, which is super exciting. And that is what allows us to offer contact hour certificates for our education materials. This course is approved for 1 hour since we'll be here for an hour. Criteria to receive that contact hour certificate is staying for 80% of the time that we're here. We have no relevant financial relationships, no commercial interests. So I'm not talking about anything that I'm like today's ventilators. I don't work for a ventilator company and I'm going to talk about that company. So no conflicts of interest there. What I would like to for us to learn today, I would want us to just gain a general understanding of general ventilator settings and modes. We're going to start with the basics. We don't get a ton of that in nursing school. So for those who are here that are new to ICU and maybe you've only had a couple ventilator patients so far, I want to make sure we feel really good about what those settings mean and what the modes mean and why we put certain patients on certain modes on the ventilator versus others. And then we're going to talk about which treatments are appropriate for various respiratory conditions in relation to ventilator modes and settings. So again, what mode for what patient? And then we want to recognize the signs of successfully weaning a patient off the ventilator. This is a really high-hitting subject for the CCRN. The CCRN is definitely going to ask about this. If your patient looks appropriate to come off the ventilator, what that looks like. And we want to make sure we really dive into that. Victor's asking, how do I get a certification for attending this course? Victor, it looks like you're on Zoom, so you've already completed step one correctly. And actually, when you just stick around for 80% of the webinar, our IT backend is able to track that, and you will get a certificate in your email box after the webinar. Might take a little bit of time, but it's usually their day of, absolutely. So yeah, you don't really have to do too much else. At the end of the webinar, I'm going to drop a link to a post test that I would love for you to take as well. And that just gives me some information on, was the webinar helpful for you? Did you learn anything in the webinar? Did your confidence in the material increase? We'll send you a link to answer some of those questions. Okay, next, I normally talk about the CCRN here, but I've already kind of covered it. Our critical care nurse certification exam, lots of good reasons to take it. Like I said, Archer Review just released a product a couple months ago. Where we've got a 1,000 plus question Q bank and 13 plus hours of on-demand lecture material. And we also advertise all of our free webinars on that same page. So if you're interested, if you're preparing for your CCRN, you're looking for more places to get practice questions, if you want to take a course like take in that type of material to study for your CCRN, head over to Archer Review and check out our CCRN product. We're super, super excited about it. And we've now officially, it's been out for a couple months, so we've now gotten some feedback that people have passed the test using our product, which is really, really exciting. It is free right now for a limited time, so definitely head over there. Good morning, everyone. Okay, so let's go ahead and dive into mechanical ventilation. Now, before I click the next slide, I'd love to see in the chats, what are some indications for somebody to be mechanically ventilated? And I mean invasively mechanically ventilated. So intubated with a breathing tube, an endotracheal tube hooked up to the ventilator. What type of patients do we see in the ICU on ventilators? Yeah, Denisha says ARDS. That's a great, great answer. We definitely use ventilators a lot in ARDS management. ARDS standing for acute respiratory distress syndrome, characterized by a lot of pulmonary edema. And a lot of times we need that positive pressure that can be provided by a ventilator in order to get that fluid out of the way of in the alveoli and allow for better oxygenation. Victor says, any patient with an increased work of breathing? Yes, especially if they're at that point of respiratory distress going into respiratory failure. That type of increased work of breathing is not sustainable. Cardiogenic shock from Joyce, that's another reason that we might put somebody on a ventilator. We don't necessarily have to, but you're right. A lot of times when we've got that heart that's really, really failing, we're going to see such a massive pulmonary impact from that we likely have to put that person on the ventilator. CABG, somebody coming back from cardiac or coronary artery bypass graft surgery, absolutely. We like to get them off that ventilator within 6 hours after they come out of the OR. But yes, ideally, they come out with a ventilator. We've got apnea, patients with an airway compromised, critical surgeries. Absolutely. Great job, everyone. So that's a great place to start. Whenever we're going to talk about anything procedural, anything therapy-wise, it's always important to start with what types of patients are actually going to receive this therapy. So indications would be we've got the primary functions of oxygen delivery and carbon dioxide removal. That's as simple as that. That is what a ventilator is accomplishing. We're improving our patient's oxygenation and allowing them to have exhalations that are adequate for CO2 removal. All of that, when we're hooked on a ventilator, is going to reduce our patient's work of breathing, allow for safe sedation administration, which is where a lot of those surgeries come into place. We can adequately sedate somebody during a major surgery and not have to worry about their respiratory depression symptoms of that sedation. And then also being on the ventilator reduces oxygen demand. So when we have that patient who's got that really increased work of breathing, they have cardiogenic shock. They're in some sort of other shock state that's really ramping up their oxygen demand. If we can take care of the respiratory system for them, adequately supply their tissues or the blood at least with oxygen, then that helps take a factor out of the equation. We don't have this patient who's been breathing 60 times a minute trying to have, save their respiratory status. Now we can take care of that for them. And like I said, when we are talking about an invasive mechanical ventilation setup, that's going to include an invasive airway, which is typically that endotracheal tube, or we can be talking about a tracheostomy through the neck. So how we're going to break this down is we're first going to start with ventilator settings, and then we're going to talk about how we use those settings to build ventilator modes. So a lot of this, if you've been in the ICU for years and years and years, this is going to be review for you for sure. This is something, we have patients on the ventilator all the time, and you're used to seeing these settings be adjusted with respiratory therapists and all of that. Now, if you're new to ICU and you haven't sat down with a respiratory therapist just yet, then some of these settings might be a little murky still. So I want to go through and make sure we're all on the same page on what these core settings do for our patients. And then we'll talk about our core modes and how they differ from each other and little tricks that I have for keeping them separate in my mind. So let's start here with ventilator settings. So first here, we've got the respiratory rate. This is a setting on the ventilator that we can set the breathing rate for our patients. So it's just how many times per minute do we want them to breathe? And we adjust this for a couple different reasons. We obviously want them to get enough air in, enough oxygen in. So we don't want them to be breathing 2 times per minute. We know that that's not adequate. But sometimes we might have them breathe even higher than normal. Normal would be between 12 and 20 respirations per minute, but sometimes we go as high as 25 or as high as 30. Can someone tell me why we would purposefully set our patient's respiratory rate higher than normal? What situations have you seen that in? Yeah, to reduce CO2, right? It's really not about oxygen at all. We aren't using that particular setting to get them more air and more oxygen. We want to blow off carbon dioxide. This is really good. A lot of people are saying respiratory acidosis, which is perfect. It's really good in respiratory acidosis. It's also really good in patients in metabolic acidosis. You get that patient into the emergency room and they are acidotic from whatever condition they may have, maybe sepsis, and they're also respiratory compromised. We're going to put them on a ventilator. Even though that's a metabolic acidosis problem, we'll still use that respiratory rate when we've got a patient on the ventilator to help reduce the overall acid in the body. We still need to fix whatever's going on metabolically for sure, but it's a really good way that we can kind of force that compensation for our patients when we've got them on the ventilator. So really any acidosis, we can adjust our respiratory rate for. Great job. So next we have our tidal volume. This one is a little bit less. Oh, Sandra, you took your NCLEX and passed. Awesome. Thanks for coming on and saying thank you. I'll let the team know. So tidal volume, we are going to use really what's just set for the patient. We're not adjusting this as much as some of our other settings because tidal volume has risk associated to it. So this is the amount of volume that with every single breath, this is what we're setting the patient to receive. This really is specific to modes where we're controlling the volume. And we'll get to those modes here in a second, but there's some modes that we say, hey, every breath you're going to breathe in 500 cc's of air. And there's some other modes where we say, actually, we're just going to give you a certain amount of pressure to help you take in air, but we're not setting how much air you're actually going to take in. Now, normal here is 6 to 10 milliliters per kilogram. It's all based on the size of your patient. We don't want to set tidal volume for that 90-pound, 4'11" grandmother, they need a very different tidal volume than someone who's 6'2" and 350 pounds. So we use kilogram to help make sure we're giving our patients a safe tidal volume. If we put too much air in the lungs, we can really cause some damage to the alveoli. Over distension is a huge problem. So 6 to 10 milliliters per kilogram is standard. When we start to talk about ARDS, those ARDS alveoli are really, really sensitive, and we don't want to overexpand or over distend those alveoli. So we'll do a slightly less milliliter tidal volume for ARDS patients, and we use higher pressure so that we can keep alveoli open but not over distended. Next, we have oxygen concentration. This is probably our easiest setting. We all know what this is. This can range from 21% to 100%. 21% is our atmospheric oxygen amount, so we won't go lower than that. And 100% is the maximum amount of oxygen. This is no nitrogen in that air at all, no other gases. We're 100% oxygen, which has some risks to it as well. So we really want to only be using as much oxygen as we actually need. But yes, that's the setting there, 21% to 100%. Next, we have PEEP. PEEP stands for positive end expiratory pressure. This can be 3 to 5 centimeters of water, but I'll say it really can go all over the place, especially when we're talking about ARDS. We can get really quite high with PEEP. I remember when COVID was happening. I'm sure a few of us here remember that time. And the PEEP settings for COVID were really, really high. We could be up in the 24s, 20. I don't know if I ever saw 26, but I definitely think I saw 24 as the measurement for PEEP. So really, really high. And what PEEP does for us, I'll ask a question here. Oh, somebody's asking me a question. What's the maximum safe PEEP for a patient with severe ARDS with a PF ratio of 78? I don't know. I do not know. That's still, even though you gave me a lot of information, I still don't have enough. And with me being, an ICU nurse, feel like I have a good understanding of PEEP, but I'm still not the one making that particular decision. So yeah, good question, but it's so patient dependent and it's a team decision. The respiratory therapist, the nurse, the ICU provider, all working together to decide these settings. So really quickly, with positive end expiratory pressure, what we're focused on here is the amount of pressure that we can keep in the lungs after expiration. So normally, when you and I are breathing here, we take a breath in, we fill our alveoli with air, oxygen exchange occurs when those alveoli are open and filled with air, and then we exhale and those alveoli collapse and oxygen exchange no longer is occurring because those alveoli are collapsed. What PEEP will accomplish is keeping a little bit of pressure in the lungs after we breathe out, after exhalation, to allow the alveoli to stay open and increase the amount of time for gas exchange to occur. So with that knowledge, when we are thinking about adjusting PEEP for our patients, are we going to adjust PEEP for, let's say, a hypoxia issue, a really low oxygen saturation issue, or are we going to adjust PEEP for a carbon dioxide issue? What do we think? How would we use PEEP? Great job, Shakira and Victor. Perfect. Yeah. Good job, Joyce. So this is oh gosh, frog in my throat. We are going to adjust PEEP for an oxygenation issue. When we want more time for that gas exchange to occur, which really is going to allow for more oxygen to make it into the blood. So we've got that patient who's on really high FiO2, anything over 80%, then maybe they're on 90%, maybe 100% FiO2. We're starting to think, well, we can't go much higher here, right? We can't give this person any more oxygen. So then we can adjust PEEP. And a lot of times we're adjusting PEEP before we get to those skyrocketed amounts of oxygen. But it's another setting that we can use to increase blood oxygen content as we're increasing the amount of time that oxygen can get into the bloodstream. So oxygen concentration, or FiO2, and PEEP are what we're using to increase oxygen status for our patient, increase our oxygenation. Respiratory rate, and sometimes a little bit of tidal volume, but again, that's more fixed, determined on what the patient's really going to tolerate, is what we're using to adjust for carbon dioxide levels. So when you get that ABG back for your patient, you're thinking, if it doesn't look the way you want it to look, you're instantly starting to think through, well, what settings on the ventilator do we need to move around to make this blood gas look better, to get the patient more oxygen, or to get some CO2 off. We're in a respiratory acidosis. And then you're kind of putting your ventilator settings into different categories of what can we adjust for what. And again, with us not being respiratory therapists, from the ICU bedside nurse perspective, I'm thinking mostly about respiratory rate. Can we make adjustments there? FiO2 and PEEP. Whereas I leave tidal volume changes more to the respiratory therapist to kind of walk through what would be best for that patient, as that's a little bit more nuanced. Now, finally, here we have our pressure support setting, or our pressure. This is the amount of positive pressure we're having the patient be assisted with. So usually, depending on what mode we're on, we either have a set tidal volume or we have a set pressure, that inhalation assist. If we have a set tidal volume, we don't really have a pressure support setting, because we're giving that breath the volume. Whereas with a pressure setting, we're saying when a breath is triggered, either by the machine or the patient, we're going to give an amount of pressure to help the patient breathe in a certain amount of volume. This can vary again. 5 to 10 is common, but this can go as high as 15, even higher than that, even up to 20. So yes, we're usually seeing either tidal volume set or pressure support. The rest of these settings are typically there. Now, if we're in a mode on the ventilator that is allowing the patient to fully be in control of their own respiratory rate, then we might not have a set respiratory rate. It'll be on a backup, and it'll say if the patient's not breathing 10 times a minute at least, then let's kick in and give this patient some breaths to prevent apnea. So we can set a backup rate here, but if we want them to be fully spontaneously breathing, we might not set a respiratory rate either. When we're on full dependence on the ventilator, we'll definitely have a respiratory rate. So I've kind of teased the ventilator modes here just a little bit with talking about those settings. So we use those settings to create ventilator modes that are appropriate for different types of patients. So all a ventilator mode is how the machine is going to work to ventilate that patient or client. So these modes, I break them down in a couple categories. This is how I have always taught vent modes when I am training a nurse that's either new to ICU or a new grad nurse. This is how I break it down for them. And it seemed to be pretty helpful, but you'll have to let me know if it's helpful for you. So the first thing that I'm thinking of when I'm thinking about vent modes is, what is the set trigger? What is responsible for giving this patient breaths? Is it the patient? Are they responsible for spontaneously breathing and initiating their own breaths? Or are we setting the trigger to the machine and saying the machine is going to deliver 15 breaths per minute? That would be a machine triggered mode. So that's the first thing I'm thinking of. Are we in a patient triggered mode, or are we in a machine triggered mode or ventilator triggered mode? Now, the second thing I'm thinking of to determine the mode is how, whenever the breath is triggered, no matter who it's triggered by, patient or machine, how is that breath being delivered? Is it being delivered as a volume amount? So we're setting that, that tidal volume. Or is it being delivered as a pressure amount? And we're saying, hey, we're going to give you that 5 centimeters of water of pressure, and that's going to help you inhale, but your tidal volume might actually vary as the patient takes different size breaths, but we're helping them with the same amount of pressure. So again, trigger is it patient or machine triggering their breaths? And then we talk about, how is that breath being delivered? Is it a volume being delivered, or is it a pressure being delivered? The ventilator modes that we talk about are then going to be a combination of those various modes, of those various options. So we've got 4 modes listed out here, and the ones on the left involve machine triggered modes. The ones on the right involve patient triggered modes. And then we can look at them for top versus bottom as well, kind of viewing this as a table. These top modes are volume modes. So we're setting a certain volume that we're going to deliver to the patient. And the bottom modes here are pressure modes, where we're not setting a certain tidal volume, we're just setting that inhalation pressure assistance. So the most common modes that you will see in the ICU are your ACVC, which is a machine-triggered volume mode. This is for when we have that patient who is comatose, we have them highly sedated, or just for their neurostatus, they don't have a sufficient neurostatus to control their own respiratory rate. This is full support. We are controlling everything for this patient. They do not have to have a respiratory drive at all, and they will still breathe because they're on this particular mode. Now, the second most common would be at the opposite end of the chart here. So it's completely opposite for both of those settings that we talked about. We have patient-triggered pressure mode. So this is when we have that awake patient who's able to spontaneously take breaths on their own, and we're just giving them pressure to help them pull tidal volumes. We're not telling them exactly what tidal volume we want them to breathe every single breath with a tidal volume. They're determining that on their own. This is a really good weaning mode. This is when we think a patient's probably close to coming off the ventilator. We can put them on a patient-triggered pressure mode, most commonly pressure support, and see how they do on a mode like that. If they do pretty well, we can get them off the ventilator. And we'll talk about what doing pretty well looks like a little bit later. So again, those are our main ones that we see. Now, our third most common would be this pressure control. This is where we have a machine triggered, so we're setting a respiratory rate on the ventilator, but it's a pressure mode. So we're not saying that every single breath that patient has to breathe 450 milliliters. We're just giving the same amount of pressure for every single breath, and that tidal volume might vary slightly. Now, something to consider with our ACVC is this is a very uncomfortable mode, which is what makes it very appropriate for when we have a really sedated patient. Because in this mode, the patient is still allowed to breathe spontaneously. They're allowed to trigger their own breaths, but that breath is going to be treated the exact same as a machine-triggered breath. And you know that when we are just minute to minute, we're taking various sized breaths. Some breaths are really deep inhales, deep sighs. Others are really short and just small, normal breathing breaths. So we have a lot of variability in our tidal volumes normally. This is not going to allow for that. Every time that patient, whether the patient initiates a breath or the machine sends them a breath, it is going to be the same tidal volume every single time, which can be really uncomfortable. As soon as we start to see that patient waking up and they're on ACVC, we have to ask ourselves a couple questions. Are they waking up because we want them to? We've kind of reduced some sedation. We're trying to get them to wake up. Maybe now they're ready to be switched to a different mode, a more comfortable mode, like pressure support. Or do we think there's too much going on with their status? We really don't want them to wake up and be in control of their respiratory status yet. That's when we need to provide them with more sedation to ensure that they can be comfortable on a mode like this. When we still want to be in control of everything respiratory-wise, there's still a little bit too much in the woods. We can keep them on ACVC, but we need to sedate them further because they're going to compete with that respiratory rate and start breath stacking when the machine triggers a breath, they trigger a breath right on top of it. And again, it's really uncomfortable and it can cause a lot of overdistension in the alveoli. We're at risk for barotrauma. There's risk associated. So as soon as we have a patient who's too awake for ACVC, we need to be thinking about some other options. Machine-triggered pressure mode is common when we have that need for a set respiratory rate, but we are worried about barotrauma with the alveoli. We don't want to say that they have to take 400 cc's of volume every time. We want to just give them pressure and allow them to inflate as much as they can, what their lung compliance will allow for. That's when we can use pressure control. And it's got that control word, I've got that underlined here, because we're still controlling the patient's respiratory rate. When we aren't controlling the patient's respiratory rate and it's the patient's job to determine it themselves, we'll use that support word, pressure support, or volume assured pressure support, which is when we've got patient triggered, but we're giving them a certain amount of volume whenever they take their initial breath. That is a very uncommon mode. In fact, I'm trying to think if I've ever even seen it. It's very, very uncommon to have the patient take their own breaths, but then force a certain amount of volume on them. this pressure support is much more common. Now, another mode that we must talk about is SIMV. This is a mode that you might see a lot, especially if you're working in a post-surgical unit. I know I did cardiac surgery for a long time, and I saw this mode a lot because what's helpful about it is it will adjust for what's happening with the patient. So it doesn't really fit into any of the categories that we saw on that last slide, because again, it's going to move around. We can have somebody come out of the operating room and they be on SIMV, synchronous intermittent mandatory ventilation. And that could look very, very similar to ACVC at the time. They come out of the OR, they're really, really sleepy. They don't really have a respiratory drive of their own. They're getting a certain respiratory rate and a certain tidal volume every single breath. Now, the ventilator will adjust when it notices that the patient is taking breaths on their own. And instead of sending, that same tidal volume for those patient-triggered breaths like we saw in ACVC, what we'll see is they will treat that spontaneous breath a little bit differently. Maybe just give them a little bit of pressure to help with their spontaneous breath, but then it makes it more comfortable. And slowly but surely, if that patient wakes up fully and now they've got an adequate respiratory rate that matches whatever the rate was set when they were sedated, let's say it's 16 breaths per minute. If they're spontaneously hitting that 16 breaths per minute, SIMV will pretty much turn into pressure support for them. And they will just be assisting the patient where it's needed. The ventilator is able to adjust for the patient's respiratory effort. So it's a really good mode, again, for that post-surgical patient that really doesn't have necessarily a respiratory concern. The reason they were intubated was for surgery, and we're expecting to wake them up and wean them off the ventilator relatively quickly. We can use SIMV really well. It's not the only situation that we use it in. It's actually a great vent mode for lots of different reasons. But that's a really classic example that we see it. And because it adjusts for that patient's effort, that's what makes it not totally fit well into any of those other categories. Now, let's talk quickly about some complications that we can see with invasive ventilation. One of the main ones that we're really concerned about is lung injury, ventilator-induced lung injury. This is also called the VILI or VALI, ventilator-associated lung injury. And this is from where we have barotrauma or volutrauma, so too much pressure or too much volume, and it causes the alveoli, which is a really sensitive capillary bed, to experience air leaks from being over distended. We put too much pressure and too much volume on that alveoli. And that air is going to start to leak out into the pleural space. We can get pneumothorax from this. And that can be a really huge problem. And that's why for certain types of conditions, we won't use ACVC because we don't want to slam a certain amount of volume into the patient every single time if their compliance is really, really low. We'll use pressure modes in those settings because they are gentler on the lungs. We can have a gastrointestinal impact where air can enter the stomach, especially during intubation itself, but also throughout mechanical ventilation. We can have a risk for vomiting due to gag reflex stimulation during intubation, but also just throughout the time of the patient being ventilated. Asynchrony is really, really common. This is what I was talking about, where you've got a patient on a control mode where we're setting their respiratory rate for them, but they start to wake up, they're taking their own breaths, and they're starting to stack breaths where the ventilator is trying to give them a breath and everything's really desynchronous. To fix this, we either need to sedate the patient properly to be able to tolerate their mode or assess maybe they're ready to go onto more of a spontaneous, more comfortable mode. So that's kind of the decision we make when we see that desynchrony. We can have a cardiovascular impact. Ventilation really does increase the intrathoracic pressure, especially if we're in a high PEEP setting. PEEP being that positive end expiratory pressure. So it's keeping the alveoli open even after expiration. If we've got lots of PEEP, we are really increasing our intrathoracic pressure. This can put pressure on our superior vena cava and reduce our preload. We can reduce that venous return into the right side of the heart. And if we're reducing preload, we are running the risk for reducing cardiac output. And finally, here, one that I'm sure if you're working in the ICU, you are well aware of this risk. This is ventilator-associated pneumonia. We have bundles in place at a lot of facilities to prevent this because we can see infection from there being that endotracheal tube in place. So we do frequent oral care. We keep head of bed over 30 to 45 degrees in case we have some of this vomiting or there's gastric contents that come up. They won't get down into the lungs. Let's quickly talk about alarm management. Really simple slide here. What we're typically seeing when our ventilator alarms is high pressure or low pressure alarms. And those alarms are going to tell us that a couple different things are happening. Now, one thing to mention, when you walk in the room and your alarm is ringing, what is the first thing that you're going to do? Yeah, great job, Ram. Check the patient, right? We're going to look at the patient first. And I can be guilty of this. When I first walk into a room, sometimes the first thing I'm thinking of is silencing the alarm, which is important. I will say it's very important to silence your alarms, especially if you're, assessing what's going on. We get alarm fatigue a lot in the ICU, and I will get extra help if I need it. I don't want my alarm to be the one doing that. But yes, we're going to walk in and assess the patient, see what's going on. There might be something on the patient that's clearly causing the problem. And if we just go straight to the ventilator and look at what it's saying, we might miss something really obvious and get really caught up in the flashing and the words that are popping up on the screen. Look at the patient first. Because a lot of times it could be, especially for these high pressure alarms, secretions. You can actively see that your patient's coughing and that their tube is filling up with secretions. And then without even looking at the ventilator and seeing high pressure alarm, that's what it is, and that you need to perform some suctioning on that patient. Um, are there kinks in the tubing? The other one, the low pressure alarm, sometimes again with that coughing patient, they might just cough the tubing right off of their endotracheal tube, and there's a disconnection that's now occurred. Those would be more obvious that if you look at the patient first, you can really quickly handle it and resolve the alarm really, really quickly. Now, let's say you look at the patient and they're not coughing, there's no secretions, their tube isn't disconnected. That's when you can look at the ventilator, silence the ventilator, say, what's going on? What is it telling me? And if it's a high pressure alarm and you don't see those secretions, you've tried suctioning, there aren't any kinks in the tubing, the patient's not awake, so there's no biting the endotracheal tube happening. That's when we would be concerned for either a bronchospasm or a pneumothorax. When we get that high pressure alarm, if we cause volume trauma or barotrauma to an extent of a pneumothorax, we're going to get that high pressure alarm because there's now a whole lung or a whole area of a lung that can no longer ventilate. And it's blocking air from entering the lungs because that lung is deflated. So that would be a reason that we would get that really sudden high pressure alarm, and it's not one of these other problems going on. Low pressure alarms is when we are worried about a leak in the circuit, disconnection, or an extubation. Another reason that you look at your patient first. Make sure that they still have the tube in their mouth. That is absolutely going to cause a low pressure alarm if they remove the tube altogether. Okay, good job. So let's talk about ventilator weaning. I would say on the CCRN, this is going to be a really important thing to feel really good about. And if you've worked in the ICU for a while, you've probably walked through this process with your patients quite a few times. So hopefully it's something that you feel pretty good about. But we're going to walk through it here and really nail down what counts and classifies as a successful wean or an unsuccessful wean. So first I want to talk about our stages of weaning. We've got three of them. We've got our pre-weaning stage, our true weaning stage, and then what it looks like when we have a failure to wean. So with our pre-weaning stage, what we're concerned about is assessing for readiness. Can y'all tell me what are some things that we're assessing for to determine if a patient is ready to try weaning their ventilator? let's say they're on ACVC, a full control mode. And we're thinking, well, their numbers are looking a lot better. They've been on the ventilator for a couple days now. They might be ready. What type of things are we looking at? Shakira says ABG. That's really, really good, right? We want to make sure that looks good. We're not going to remove respiratory support when those numbers aren't even fixed. So that's great. Um, Yes, correction of reason for intubation. Why did we even intubate this person? Is that better? That's a really important thing to think about with those patients that we don't intubate for respiratory reasons. There's lots of reasons that we intubate, right? And one of them, we talked about the cardiogenic shock being one. That's not a true respiratory problem, but we are using a ventilator to help us support that patient. So we want to see that that problem has resolved. Are they able to clear secretions? That's a good one. How strong is their cough even with the tube in? How alert are they? Very, very important. And that a couple people have said something like that. Independent breathing. How alert are they? GCS of 8 or above. Absolutely. We need to make sure our neuro status is adequate for them to breathe on their own. Positive cuff leak, and some people mentioned other, like the NIF and RSVI, yeah, RSV test. Minimal sedation, ability to follow commands. Absolutely. So we've got that patient and they are following commands. They are breathing on their own. So we can see that their respiratory rate is maybe above, if they're on a control mode, their respiratory rate's above their set rate. Following commands, they're coughing. Then we think, okay, we're pretty much we're in a good spot. Their ABG looks good. We've checked that pulmonary function. Neurostatus is adequate. Cardiac function has stabilized. Doesn't have to be perfect, but it's a lot better than maybe when we originally intubated. And the last thing here is fluid status is stable. I have definitely had this happen before where we've got a patient that overall looks really good, but then we think, oh, wait a second, they're still 20 liters up. We are maybe working on diuresing them, or we've got continuous dialysis going and we are, kind of struggling to pull as much fluid as we want to pull. We don't want to extubate a person or a patient who has a lot of fluid on board. If they've got +2 pitting edema everywhere else and we're still worried about fluid on the lungs, that's not setting them up for success. So fluid status is another thing that we don't always think about, but is an important thing to consider when we're thinking about weaning a patient. Now, when we get to that weaning stage, we're going to initiate a wean trial. And this is when we change those ventilator settings to decrease the amount of support that we're giving them. So we're going to change them to a pressure support mode most typically. This is where we are saying the patient's responsible for their respiratory rate, and the patient's responsible for taking in a full tidal volume in with every breath, but we're not going to be giving that tidal volume to them anymore. We're just giving them a little bit of pressure, usually about 5 of pressure to help. We've got this long breathing tube in place, right? This endotracheal tube. So the pressure of 5 is not true support. It's just to help them breathe through that straw that's in their throat. So we'll give them just a little bit, but again, it's not true assistance. So if they can go to pressure support, be responsible for their own respiratory rate, and they're on usually that pressure support of 5 over a PEEP of 5. We have to have some amount of PEEP anytime we're on the ventilator. It can never be 0. Again, because of the tube being in place, we need a little bit of pressure to keep things open. And then we're going to set some timing to this. For those patients that come out of the operating room, maybe after that coronary artery bypass surgery, the CABG surgery, other major surgeries, and we're anticipating them waking up and being able to breathe normally. They didn't enter surgery with any sort of respiratory complications. We think this will be a quick wean. We could do a weaning stage or a trial time of 30 minutes. And if they look good, all of their numbers look okay, and we'll talk about what that looks like here in a second, then that's sufficient. Some patients only need that 30-minute weaning trial. Now, when we have patients who have been on the ventilator for multiple days, and their respiratory system is their main concern, that was the reason they were intubated, we might need to see much longer weaning trials. And this is a lot of times for those patients who maybe were intubated for 7 days, they got a tracheostomy in place, they're still on the ventilator. Now we're starting to work them up for maybe trying to be on trach collar. This is when we could do 2-hour weaning trials. And then the next day we do 6-hour, and then we try to get them to 24 hours before we do anything crazy. That's how long this can last. So we really have a wide range of what that weaning stage can look like. And it really depends on what did that patient initially need. Again, if they were intubated for non-respiratory reasons, then weaning trials can be very short. If they were intubated for respiratory reasons, we really need to make sure that they don't need that ventilator anymore because they definitely needed it at some point. So what does it look like if we put our patient on that pressure support 5/5, which just means we're giving them 5 of pressure to help with inhalation, and we're keeping 5 of PEEP in there to help just keep alveoli a little bit open. So those are bare minimum settings. We've had the patient on them for a few minutes. What signs would we see? Or maybe it doesn't really matter how much time they've been on it, but they're on that setting. What signs would we see that we say, oh, this isn't going to work? We can't extubate them just yet. What would our patient look like? Yeah. Shakira says apnea. That's exactly right. They stop breathing altogether. We lose that respiratory rate support, and they actually don't continue to breathe on their own. So that's a great one. Ram says increased work of breathing. Absolutely. When we start to see tachypnea, that is a major problem. So any side of a not normal respiratory rate is a problem, apnea or tachypnea. Extreme lethargy. Yeah, they get really, really tired because they're not able to support the respiratory system on their own. Increased respiratory rate. Absolutely. What are some other things that maybe don't only relate to the respiratory rate? What other things could we see that we would say, they're probably not ready? Yep, SVT. If we see any sort of heart arrhythmias, we know that we're really stressing that heart out by removing some support. Can't maintain SpO2 above 90. Confusion might be hard to assess just because they've got that breathing tube in. So we might not be able to, they're not able to tell us anything, but we could see that maybe they're not following commands as well. Yeah, that hypoxia, SpO2 above 90. The Shakira mentioned SVT. That's super good. When we have that fallout of respiratory support and the heart rate goes really, really high, we know that the body's freaking out a little bit. It's the same thing with that tachypnea. We're seeing respiratory distress symptoms on someone who's still intubated, and that is a huge red flag telling us, whoa, they still need support if they look like they're in respiratory distress and we're seeing these and they're still intubated. ABG changes, absolutely. Every facility does this differently. Likely we will, if it's that post-surgery wean, we might not send an ABG while we're in a wean with them, but sometimes we absolutely do. Sometimes we just use clinical signs. It just kind of depends. But for those more complicated weans, we'll definitely send off an ABG and make sure that they're not starting to retain carbon dioxide or starting to get hypoxic. Great job. So yeah, a couple other things we can see. So we talked about apnea, tachypnea, hypoxia, anxiety, use of accessory muscles. I think somebody in the chat over here said that with retractions. Absolutely. And then heart rate and blood pressure changes. We can see that go a lot of different ways. If we see that heart rate elevate and the blood pressure get high, that's just telling us this patient's struggling to get oxygen and the other body systems are kicking in to compensate. Awesome. So this is what we would determine as an unsuccessful wean. We can take the opposite as a successful wean when we have a normal respiratory rate. The other number that I didn't mention, because it's not really a setting, but it's a number I really, really look at when I'm assessing a patient's successful wean, and that is their minute ventilation. Their minute ventilation is how many liters of air are they taking in over a minute. And I look at this before we start the weaning trial. So if you've got a patient on ACVC and they're getting 500 cc's, oh gosh, I should have done the math for this before. They're getting 500 cc's per tidal volume. That's their tidal volume. And then we've got them set to a rate, what would make easy math, 16 breaths per minute. I want to say then that's like eight liters per minute. Oh, I should have done it before. Anyway, you just take that. So they're taking 500 cc's times that 16, they're getting 8 liters over the course of a minute. That's when we're fully supporting them, right? So then when we switch them over to pressure support, I'm looking at their minute ventilation because I know that when we take breaths moment to moment, we take breaths of all sorts of volume. So I don't want to just look at my patient's tidal volume and say, well, when we were on ACVC, they were set to 400, and I've seen a couple breaths that they're only taking 150. They must not be taking adequate breaths. That's not really fair because we know that they can take volume breaths of all sorts of volumes. So it's important to think about minute ventilation, which is the average, like the amount of volume we want to see them take in per minute. Are they reaching that number? Regardless of what their tidal volumes look like, because one might be 800, one might be 100. Are they reaching the same amount of volume over the course of a minute that we were seeing on full support? That tells me they're getting enough air in every minute. So that's another thing to look at that I always tell people to take a look at that minute ventilation before we move them to pressure support, because that's what it looks like when they're perfect. And we want to see if they can keep up with that when they don't have as much support. Okay, great job. Really quickly, I want to talk about, oh, got a question here. How do you analyze and intervene when you see an event on the ventilator? So if we do see the patient go apneic on the ventilator, luckily, pretty much every time, sometimes this is a little different when we are weaning them because we want to see if they're going to go apneic, but a lot of times we're going to put them on a backup rate, even if it's really low. We'll put them on a rate. So even if they're on that pressure support where we're not setting a respiratory rate, the ventilator can still have a backup rate in place for if that patient goes apneic. And that's when the ventilator will still tell us, like, hey, your patient went apneic. We're giving them backup rates, but they are not taking breaths on their own and they're on a mode where they should be. So that's when it'll alarm and say your patient's apneic. This is when you call your respiratory therapist and you say, okay, we failed the breathing trial. A lot of times they stay pretty close by if you're doing that spontaneous breathing trial. And you say, hey, they failed. We're apneic in here. And they will come in quickly and put them back on that full support mode. There should be no reason that, again, it's because it's got a backup vent. You don't need to start bagging the patient or any of that unless something's going wrong with the ventilator itself. You really should just be able to say, okay, that's a fail. We can switch them back over. One thing I want to talk about really quickly, you're welcome. One thing I want to talk about really quickly is ARDS. ARDS uses a vent mode that we didn't talk about, which is APRV. And I'm not going to spend too much time on it, but it's really where we are using lots of high pressure to help protect the alveoli. So instead of using high volume, we're using pressure. And we're increasing the inspiration time. So we use really, really high pressure, kind of with like really fast, high pressure, and then little moments of letting the pressure out so that we can get carbon dioxide removal. The other thing that we do for our ARDS patients or any patient who's we're really struggling to oxygenate them is prone positioning. So I just want to throw this in here as something to think about when we're talking about mechanical ventilation. Be thinking about what other things can we do for our patients if we're really struggling to get that oxygenation under control. This is very common with ARDS, and we did this a lot with COVID ARDS, but we do it with ARDS all the time. This is really indicated for those patients with a P to F ratio of under 100. Now, what P to F ratio is talking about is we take what is their PaO2, which is their plasma arterial oxygen content. What is that number? I think I've got a slide talking about this, divided by how much oxygen are we giving them, their FiO2. So let's take this example. This is a PaO2 to FiO2 ratio. We call it a P to F ratio. If we've got a PaO2 of 55, which is low, that's hypoxemia for sure, and we're giving our patient 80% oxygen on the ventilator, that would be a 55 over that 0.8 for 80%, that comes out to a P to F ratio of 69. Normal is over 286. So this is really, really low. And if we're on the ventilator and we're on an FiO2 of 80%, that's a lot of oxygen support. Who knows what our PEEP is, but let's say our PEEP is really high as well, and we're still getting this PaO2 of 55. we are out of options. We need to try something else. And that is when we're going to think about proning. And hopefully we've thought about proning before we get to that point as well. But this is when proning might be helpful. What proning is going to do, especially in ARDS where pulmonary edema is such a problem. If you think about how your patient's laying in bed, the supine, like the posterior portions of their lungs are filled with fluid because fluid's going to follow gravity. And so is blood flow. Blood flow is also going to follow gravity. So we've got our posterior portions of the lungs with that supine patient filled with fluid. And we're also sending all of our blood flow to those bad alveoli that are filled with fluid because that's where, it's going to follow gravity. When we flip a patient over onto their belly, we've got that means if we've got unhealthy lung tissue in the posterior portions, then we've got healthy tissue in the anterior portions. So if we flip that person prone, we can send more blood flow to those anterior portions. Now, we'll typically do this in 12 to 18-hour sessions because eventually that pulmonary edema is going to come down to those anterior portions as well. So we'll kind of flip the patient back and forth every 12 to 18 hours so that we can be constantly sending the most amount of blood flow to healthy lung tissue as possible. That is definitely the goal. Now, this does two things for our patients. It's going to improve their oxygenation because we're going to be sending blood to the healthy alveoli that can oxygenate the blood better. And then two, we're really significantly reducing our ventilator associated lung injury risk. This is a huge reason why prone positioning is very helpful for our ARDS patients. We're sending more blood flow and more airflow to healthier lung tissue, and it reduces the risk of damaging those unhealthy areas of the lung. Just safety wise, we have to consider the needs for multiple team members. And we do see more pressure sores from the positioning. It's harder to reposition these patients and endotracheal obstruction risk. Those risks are higher when we have prone positioning. So it's something to keep in mind when we're taking care of these patients. The only firm contraindication for prone positioning is an unstable spinal fracture, just due to what's all involved with flipping this patient over on their belly and keeping them there. So that's really the only reason. The rest of them are determined on a case-by-case basis. Okay, we made it pretty much right to the end here. We've got another webinar coming up next Monday at 12 Central. Really quickly, I'm going to drop the post-test link in the chat. Maybe. So if everyone could go and just take this, it should take just 2 minutes, if that. Really, really quick little post test just to let me know how, if you learned anything today. It was a fun little discussion. Do you see it now? I just put it in that. Oh, let me see. I see what I did. Thank you for telling me. Now we should see it. So yeah, really fun discussion on mechanical ventilation. I know some of it was probably a lot of review for those seasoned ICU nurses, but I hope that you were able to learn something new today. And we will see you next week for multi-system. We're going to just do a rapid 30. So we're going to go through practice questions and touch on some concepts that way, just to help you prepare for your CCRN. Is anyone taking their CCRN soon? Anyone got it coming up? Luke, within the next month. Awesome. Good luck. I hope this was helpful for you. Luke, were you the one? I feel like you said you were. Yeah, 5-year nurse, but new to ICU. Awesome. But you've got tons of experience. Um, Maybe in June, the first week, not booked yet. You keep pushing it back, giving yourself up to 30 days. I do not blame you. I've been there before. Um, and someone else is taking it in June. Awesome. That's a good amount of time to study for it. I say anywhere between like 3 to 8 weeks is probably normal for studying. You can obviously do whatever you want. whatever works for you. But good luck to everyone who's testing. I know it can be an intimidating exam. What I will say about it is it's less tricky than, say, the NCLEX. It's more just assessing knowledge, which is nice, but that does make it difficult. The content is difficult. So it's not that it's easy, but it's not tricky. So I hope that gives you some assurance. And luckily, it's all multiple choice, no select all that apply or anything like that. Thank goodness. Okay, thank you guys so much for being here. We will see you in the next one. Done. Should we expect you should get your certificate usually like within the next hour. It should be pretty quick. And you can email professionaleducation@archerreview.com if there's any sort of problems with your certificate. Okay.